recording the session, and
I really want to record it.
I am recording it now as we get started so that I can begin by telling you that our speakers, Jessica Sawyer and Thomas Weathers, and after I do my intro slides, I will tell you more about our speakers, who they are and what they do, and then I will be turning it over to them. They are in Raleigh, North Carolina. I am in Asheville, North Carolina, and they tell me that they are having a storm a rainstorm, a heavy rainstorm where they are. So we are all hoping that that won't cause us any technological problems today. So at its core, financial social work is about personal, professional, financial, and social change. These rocks demonstrate that it is based on and incorporates very basic social work principles and ethics. I did not do these rocks, but was fortunate enough to find this photograph a number of years ago, and I feel that it really captures a lot of what my work is all about. Because taking greater responsibility for your financial future requires more than just learning new financial skills. It is a process. Financial stability is a very personal, individual, and emotional choice. We make it daily, weekly, monthly. The problem is when we don't make it in each of those time frames, very often we really need to make that choice minute by minute and hour to hour. Life is indeed about the choices we make. The psychosocial component matters because until and unless behavior changes, nothing changes. So financial social work is a behavioral model. It is interactive and introspective, and we will bring some of the interactivity to this webinar with a series of polls that you can and hopefully will participate in, and we can learn more about who our audience is and the things that you do and are involved with. Financial social work facilitates the choice to take greater responsibility for creating a better personal and financial future through ongoing education, motivation, and support. And we do that because we know that those are the elements required to truly create sustainable long-term financial behavioral change. And what's it all about? What does it look like? The basics are the basics, and that means that our relationship with our money is what drives our financial behavior, and our financial behavior determines our financial circumstances. So if you want to know why you are in the particular or specific financial circumstances you're in today, you can see through this equation that it's your past choices that have brought you to where you are. So if you want to be in a better and different place in the future, you need to make better and different choices in the future. So financial social work strives to change the conversation about money, to provide a different way of thinking about money, and to offer a better way of working with clients around money problems and issues. Let's do this first interactive poll, and then I'll do some housekeeping with you, and we will turn it over to our presenters. Okay, so in order to understand our audience a little better, I'm asking you to tell us if you are an addiction professional, if you are a family member, if you're someone in recovery, if you're someone in need of recovery. Well, very interesting. We have about 75% of you have let us know where you fall on this continuum. And I think that that will be helpful, and that this webinar will provide information for everyone in attendance. So we're at 90%. If the rest of you want to join in, I'll give you just a few more seconds, and that will be 5, 4, 3, 2, 1. Okay, so we got up to 94% of you who voted, and I will close that poll and I will share it with you. So 25% of you work in the addictions profession or field. We have a little less than 10% of family members with us today. 2% of our attendees are in recovery, 1% in need of recovery, and 63% of others. So as a housekeeping point, let me say that all of you attendees should see a box up in the right-hand corner of your screen, and in that box it is a place for your questions. And some of you have already helped me out with this. I was going to say, if you would be so kind, you could tell us. We have a couple other places we'll be asking you for other also. If you help me out and tell me what are some of the other professions you're in. Someone is a financial professional. We have some housing case managers, an author, speaker, and personal financial coach, credit counselors, financial wellness coordinator, EAP, gambling treatment, financial counseling. Oh, thanks everybody. Domestic violence. Wow, great. We have some students. Well, I can see you're going to be a great group because you're sharing. Okay, social worker with the municipal government, employee assistance counselor, mental health therapist. Well, we indicated to you on your invitation what we would be doing, so all of you must have a reason for being here and be excited to get started. So I am going to hand this over to Jessica, and they are sharing, and Thomas, and they are sharing. Okay, I need to close that poll, don't I? Let's see. I think we'll be okay if I hand that off, but let me also close this poll so that, okay, I hide the poll, and now we should, Jessica, do you have it?
No.
Okay, let me hand it over to you again. You should have it.
No. You know, when you give it to me, it says, do you want to take it? That message hasn't come up.
Okay. Technological difficulties. Then I will take it back and try handing it.
Change presenters? Yeah, okay, now it's coming up.
Okay, go ahead.
No, it says Rita Wolfson was made presenter. You're no longer the presenter. Okay.
All right, hold on. I'll hand it off to you again. Here. Okay. You should have it now, Jessica.
Okay, now we have it.
Good. Okay, let me just give your background. I'm sorry, I wanted to do that. So Jessica Sawyer is an LCSW and an LCAS provisional. She's very active on the state level of NASW in North Carolina, where she's a board member. She received her BA in Sociology and Social Welfare from Winston-Salem State University and her MSW in Health and Mental Health Specialization from Clark Atlanta University. Her work has been mainly outpatient mental health and crisis services, but she does have experience with hospital, medical, social work, inpatient psychiatric treatment, geriatrics, integrative care, primary care, residential settings, and student interns. And Thomas Anthony Weathers is a provisional LCSW, an LCAS, and a CSAC. He received his MSW from UNC Pembroke, and he currently works at a health clinic in North Carolina providing integrated care. Thomas has experience working with inpatient psychiatric, jail, military clinic, and integrated care. And we are so happy to welcome both of you. So go ahead and do your thing.
Glad to be here. Hello, this is Jessica Sawyer and my co-presenter,
Thomas Weathers.
And we're going to jump right into our webinar PowerPoint slide. And as Ms. Rita talked about, we're going to talk about the financial challenges of addiction, tools to help the addict, the family, and clinician. What we want to do today is just discuss some of the financial issues that using addicts in recovery and their family or whoever they consider their support system face. And we want to briefly highlight some treatment methods, interventions, and challenges clinicians may face with this particular population. These are a list of the teaching points which were listed on the invitation. What I want to do right now is kind of define, and you can see it listed here, but I'm just going to be very brief with it. What is substance abuse and what is substance dependence and addiction? Substance abuse is basically you have to have, let me back up. The DSM-4 is the Diagnostic Statistical Manual. It's basically the Bible for clinical practice in mental health and substance abuse and learning disorders. And it just lists criteria to meet a diagnostic is to provide communications between providers so we know what and how to treat clients. Substance abuse, you have to meet one of the following criteria within the 12-month period, and it's basically where using alcohol and or street drugs, the person cannot fulfill their obligations at homework, school, those kinds of things. They might get DWIs or go to work impaired and not able to operate machines. They might have legal problems, as we mentioned, DWI or arrest, those kinds of things. And they're just continuing to use the substance despite the consequences. Substance dependency. Likewise, you have to meet these following criteria in the 12-month period, but you have to have 3 or more. And the hallmark of substance dependency is tolerance. And that's basically where when you first start drinking alcohol, for instance, you drink more and more and more, and you have to keep drinking that same amount to get the same effect when you first started drinking. Withdrawal is just basically your body is used to the alcohol or type of drug that the person is taking, and the body doesn't know how to function, so it might go into physiological or psychological withdrawal, meaning, for instance, shakes, tremors, body pains, headaches, agitation, all these kinds of things. And basically, you know, when people first start using, they might be experimenting, you know, it's young, it's fun, you know, let's drinking drugs, those kind of things. But sometimes you can get caught. And so the person might not have intended to use and stay on it this long, but they become physically and psychologically dependent. Most of their time is spent on trying to get the substance of their choice. Therefore, they may neglect work, which we'll talk about later, employment issues, money issues, those kinds of things. And it just affects all parts of their life. And the person continues to use despite the consequences. For instance, a certain drug might, like for instance, alcohol, cirrhosis of the liver, those kinds of things, nicotine, tobacco, cancer, all these types of things. These are things that we know, but they continue to use it. And these are just specifiers a clinician might use to identify the type of dependency it is. The difference between dependence and addiction. Basically, as mentioned, dependency is more about the tolerance and the withdrawal. Your body has gotten used to this drug, and without the drug, it goes through withdrawal periods. And addiction is basically the compulsive drug-seeking behaviors. It's more behavioral component. What do I need to do to get the first high or this high? That's what the person is obsessed about. Types of addiction, I'll briefly review that. Basically, as mentioned, it could be alcohol, cocaine, opiate, heroin, all those types of things. Caffeine, prescription drug abuse is pretty big now on the scene. Behavioral addictions, as we mentioned. Someone who couldn't stop control or stop an activity. Basically, gambling addiction, food, sex, love, porn, work addiction, exercise, video games, shopping addictions. Type of dependencies are, again, alcohol, amphetamine, cannabis, marijuana, all of those types of drugs. I don't know. I had a poll question here. I don't know if this reader wanted to do this particular poll. Yes. If not, I'll keep going with the presentation.
Jessica, I'll go ahead and take it back for this poll question, and then I'll give it back to you. Okay. So, give me a second, everybody. It's the way the platform works, and I need to take it back. That's not going to work. Let's see. Oh, yes. And I did change a few of Jessica's polls today. So I'm going to launch this poll. So which type of addiction-related financial problems have you experienced if you are someone in recovery, working with recovery, or have you observed? And this is such a great audience. They're going ahead without my explanation. All right. Only about 40% of you have voted. We're over 50% now. And climbing. So about 62% of you have voted. If you want to vote, go ahead and do it, and I'll close it in 5, 4, 3, 2, 1. And having asked for other, well, let me close it, and I'll share the results with you. And Jessica and Anthony, 57% of our audience said stealing by or from a loved one. 59% said job loss. 32% prohibitive treatment costs. And 50% indicated legal costs. Now, if you would like to share with us what other things you've seen, go ahead and put that in the question box. And okay, okay, someone said that she has seen all of these things. Someone said, I am a recovering addict and in college and have experienced all of these. We have seen and experienced all. Our dog track and Tunica here in Memphis, wow, has lots of gambling issues, inability to pay household expenses, loss of children, loss of custody of children, accumulating greater debt, opening more credit, bankruptcy, gambling, very simply utterly stupid decisions and uses of money when using alcohol. I've become involved with CPS from family members, payday loans, theft by deception, bank robbery, loss of home, IRS debt, hospitalization costs, incarceration. Okay. Well, thank you for sharing that. You certainly did go above and beyond my little list. Jessica, I am turning it back over to you now. Oh, wait a second. I often do that. I forgot to close the poll to take it down. Sorry, everybody. Okay, I have to find the poll. Okay. Do you have it, Jessica, or do I need to do it again?
You need to give it. The message hadn't come up yet.
Okay. Go ahead.
Okay. I hope you all enjoyed the poll question, because that's what we're kind of going to get into now, the consequences of addiction. And here are the list of bullets I'm going to briefly address. Addiction and finances. Money problems are long-term. They have deeper consequences. The solution and outcome is greater, and it requires the addict and family and all people suffering to have a lifestyle change. Most addictions have serious impact on finances. All tend to carry significant financial costs in terms of the person paying for the addictive substances. And when you are involved with alcohol and drugs, and this includes the family too, so we're all speaking of that, their life is wrapped around, as we saw in the definition of dependency and abuse, of doing things to acquire that next high. And so in that respect, while they're going after the substances, they may be forgetting to pay bills, go to work, might have got fired, all these kinds of things. So also consequences of addiction, and this is where the clinician, a trained substance abuse professional or clinician in the field, would need to address the issues of blaming, denial, stonewalling, minimizing, excusing, and all these things, and we'll go into that. Blaming, this is an instance. The addict might blame their partner for poor management or even their children. Denial is used to cover addiction from other people and to avoid that you are addicted, and you will continue to have money problems until you overcome the addiction. Stonewalling, they may say, I don't have a problem, I can handle it. The family that's the enabler or the family that's protecting the addict might say, we don't have a problem, stay out of our family's business. Minimizing, sure he drinks, but it's not a problem, it's no big deal. Excusing, I'm just self-medicating, you know, drinking, it just helps me relax, you know, smoking a joint, you know. Rationalizing, I need a nightcap to help me sleep, I deserve a reward. Distraction, you drink if you had my life. Attacking, get off my back. You got a lot of nerves talking about my drinking. So these are some of the things we might see here. Ms. Rita, I didn't know if you wanted to go into this poll question before I go into codependency in the family structure.
Go ahead, keep it. Go ahead and do that.
Okay, what we want to, this is an essential piece. Claudia Black, a MSW PhD social worker, is very renowned in the field. There's some other renowned people. We're going to talk quickly about the family structure. It's the family disease. These are two quotes that Claudia Black had put out. The words which best describe living in an alcoholic family is basically inconsistency, unpredictability, and the non-alcoholic family members try to restabilize the family system. Children growing up in this type of home learn a combination of roles that do not model healthy personalities, but they become locked in to what they need to do to survive. And this acronym, COA-ACOA, is Children of Alcoholics and Adult Children of Alcoholics. So what you see here is when you grow up in an alcoholic family, you take these traits with you for the rest of your life until you get the appropriate treatment. Family roles. You have the dependent, which is the addict, the codependent, the enabler, spouse, or partner, the responsible one, the adjuster, placater, acting out. Overall, the dependent or addict is obsessed, as we kept mentioning, with getting more drugs. They're usually guarded, defensive, powerlessness. They might appear self-centered, aggressive, grandiose. The codependent is preoccupied with saving and protecting the addict, and they may be controlling. They might have a codependent relationship with God, or maybe angry at God. This person is passive-aggressive, compliant, controlling. The responsible one is usually the oldest child, and because the addict is using and the codependent person is obsessed with the addict, the oldest child usually has to step in and take on the parental role and creates unhealthy dynamics. And as adults, these people may be rigid and enter unhealthy relationships, and they might start drinking to relax themselves. The adjuster finds it easier. I can't do anything about the family, so just go with it. Don't argue. It doesn't help to ask questions. This person may be detached, remain out of things, out of the social circle. The mascot / clown is basically the person that tries to make life easier. They might be seen as a nice person as an adult. Then you have the acting out child, the rebel. This child usually gets involved in delinquent behaviors, draws negative attention, and usually the addict and codependent and everyone in the family blames the acting out child when it's really not their responsibility. As adults, because they might have acted up in school, got kicked out, they might not have education, learn skills, problems of controlling anger, and they might have lost their job and feel powerless. What I have here is this little man you see. He doesn't know which way to go. This is the context, the family law. Claudia Black speaks of this. Don't talk, don't trust, don't feel. And basically means don't talk about the alcoholism. It's not a problem. Everyone in the family acts like it's, the elephant in the room kind of thing. Don't trust. In an alcoholic environment, it's better not to trust anyone, especially your parents, since they don't provide. So now we become emotionally detached so nobody get hurt. Don't feel, you learn not to have feelings. So if you don't talk or trust, how can you learn how to feel? So the clinician really needs to get in family therapy and involve and address these unhealthy dysfunctional dynamics. Now I will hand it over to my co-presenter, Mr. Anthony, talking about employment issues and other consequences of addiction. Mr. Anthony?
Thank you all for having me today. Continuing along the vein of consequences of addiction, we'll start with employment. One of the things that we really want our addicts or recovering people to do is get involved in the employment, try to find a job as quickly as possible. It improves their self-esteem as well as self-sufficiency. But we have to remember that it also can create additional or new problems, such as triggers or hanging out with co-workers who drink, or just the stress of the job itself. This is a person who, up to this point, in most cases, hasn't worked in a while, and all of a sudden these new stresses are presented and can cause new problems for them. Job hunting tips that I like to tell people that I have in treatment with me is learn that you crawl before you walk. Most of these guys either get out of prison or some other type of unfortunate situation, and they want to have, I guess, in a sense, what everybody else has. But what I like to remind them is that we have to crawl before we walk. And what that basically means is sometimes we have to take employment that we may not want, or we have to do jobs that we really feel that we are more qualified for, but don't necessarily have the skills or the things on paper to get us into that position. So I just tell them basically put one foot in front of the other. When you look at the entire their circumstances in its entirety, it can become quite overwhelming. And so I like to keep them focused on very small, what I call small, sustainable but consistent goals, and that is they want to set little small incremental goals that are very reachable. We have to understand that addiction has to be, in its essence, it has to be success-oriented. We build on success with an addict. So we're going to put little small goals in front of them. Hopefully they will achieve those small goals, and over time build an atmosphere of success that in and of itself builds on even more success, so that we don't lose them in that transition. The next slide, we're talking about health issues. We'll talk about both the immediate and the long-term health issues. Some of these are very obvious. These drugs are very powerful in a lot of cases that these people are taking, and they affect the body really from head to toe. There can be neurological issues, the cardiac arrest. Whenever we are suppressing and speeding up our central nervous system constantly like that, it can cause long-term problems. There are, of course, the HIV or the blood-borne diseases that are much more prevalent within the drug culture. I think it's probably 3 or 4 times higher within the drug culture than it is within the standard culture. And then we also need to take a look at the immune system of addicts. It's generally suppressed. They generally don't fight off diseases or even little common colds as readily or as well as people who are non-users do. And then we'll take a look at the long-term issues that are related to drug use. I've been doing this for a long time now, all total about 26 years, and I've never seen long-term drug use in a person, someone who's been using for a very long time. It's very common to see heart problems within these people when they're in their 40s or 50s and they decide, it's time to take a look at the problems that they've had and try to do something about it. Most of the time, they're going to have some type of heart problems as a result of all that drug use, and that really has to do with the artificial kind of stimulation and depression of the heart muscle, which is essentially what these drugs do. Particularly drugs like cocaine really speed up the heart rate. We'll take a look at some of the legal issues. One of the things, I have worked with the prison population. I really do enjoy working with that population. One of the things that I've noticed is that a lot of these guys get out of prison really with the idea that they're going to stop using. They really, very rarely do I get a guy leaving prison who says, okay, well, I'm just going to get high as soon as I walk out the door. It happens, but most of the time we're going to have people that really are committed to staying sober, but what happens is when they get out, they're faced with what I call, my terminology is the pain of change or the pain of familiarity. The pain of change really is you're asking a person to get out of jail and do something totally different from what they've always done. We know that sobriety, really, early sobriety anyway, is it's important that we do something different than what we've always done. But we're asking this person who has largely no coping skills, we're asking them to enter into something different. It's kind of, to give you an idea of what it's like, think about the first job that you've ever had, or any job where you walk on it new. Think of what you felt when you walked on that job for the first few days, the anxiety that you felt, and keep in mind also that anxiety, when we're talking about emotions, we're talking about it is a type of pain, particularly for the addict. But think about what you felt, learning new people, learning a new job, learning all these new things. Think about that anxiety that you felt. Now I want you to multiply that by about 100, and I also want you to add no coping skills to that equation as well. And that's kind of a picture of what you got for the addict who's getting out of prison, never had a job, doesn't know what they're going to do, but they have everybody in their family who's constantly telling them, you need to go get a job, you need to do this, all completely reasonable things or directives, but for the addict, the person who doesn't have that type of work history or anything, it is a brand new thing for him. So that's the pain of change. There's pain involved with that type of change that we're asking them to do. And then there's the pain of familiarity. Well, the pain of familiarity is I'm constantly in jail, I'm constantly broke, nobody trusts me, all of those kind of familiar negatives that go along with addiction. That's the pain of familiarity. Now, what the addict has to do to sustain any type of sobriety is that pain of familiarity has to outweigh the pain of change. As long as that pain of change outweighs the pain of familiarity, that person is going to choose to go back to what they've always done. Why? Because at least they understand it. The pain of change is something they don't understand. It's brand new to them, but at least this pain of familiarity, I understand it. I don't like it very much. I don't like it when people don't trust me. I don't like being in and out of jail, but I do understand it. It's predictable. And this is what you're faced with, the addict, most of the time, that pain of change or that pain of familiarity. I think at this point we'll just kind of skip over the poll questions. I think we're running out.
And Tony, let's not do that. I just want to say,
sure.
Yeah, I'll do 2 questions,
Sure.
2 poll questions now. I know this makes it a little confusing. I wanted to say that some of you are sending in questions, and I'm not sure that I reminded you to do that, but we will be taking your questions and staying to answer them at the end. So let me just do these 2 polls with you. And one is, were you raised in a family of addiction? And if you're a clinician or an addiction specialist, if you wanted to just share what you think the percentage of the clients you work with, what percentage were raised in families with addiction? Under 10%, 10 to 30%, or over 30%? Some very clearly strong feelings and insights on this question. Okay. About 75% of you have answered. And we'll just give you another few seconds. And we're up to 80%. And then I will close it in 5, 4, 3, 2, 1. And I will close it and share the results with you. So 20% of you indicate that you did grow up in a family of addiction. 27% of you say no. 3% of you feel that the clients you work with, that under 20% of your clients grew up in families of addiction. 26% of you feel that like 20 to 40% of your client population grew up in families of addiction, and 25% of you say over 40%. So it's pretty evenly divided between those of you who did and didn't grow up in a family with addiction, and leaning towards the higher percentages of clients who did grow up learning that behavior. And I have one last poll to do with you, and that is this one. So, were you, have you or a family member attended treatment that addresses the financial problems related to addiction? And if you're a professional, does your program or your work address these issues? Okay. 30% of you have voted. Oh, that's a good response on one end. So almost 70% of you have voted, and I will go ahead and close this poll and share it with you. So 5% of families and family members have attended treatments that does address the financial issues, but 20% say no, and heavily towards the fact that many programs seem to address these issues and problems. Well, thanks everybody for sharing. This time I'll remember to hide that, and I am going to give it over to Jessica and Anthony for the final time.
Okay. Now we're going to look at some types of treatment. And keep in mind that generally speaking, in substance abuse, the least restrictive intervention is generally tried first. That is outpatient, some type of limited outpatient, either education or treatment. And we gradually work our way up if people fail at the various lower levels of intervention. The short term or the outpatient is generally short term. And we also have to factor in also that the definitions for these various treatment modalities is constantly changing. I remember years ago when I used to refer people to, I won't name the agency, but it's a facility, one of our state facilities, years ago. What was considered relatively short-term inpatient treatment was around 45 days. I think now that inpatient treatment is down somewhere around 7 to 14 days. So the definitions are constantly changing, and we have to be aware of that. But suffice it to say, short-term or outpatient treatment is generally short-term. SAILP, particularly the SAILP, is much more longer term, but it's on an outpatient basis and pretty intense. Generally, people are going to meet 5 days a week, maybe 4 hours each day. So it's a pretty intensive outpatient treatment regimen. DWI is generally done, they like to term it as short-term or long-term. And generally, just to give you kind of an hourly idea of what it's like, the short-term would probably be around 20 hours, while the longer-term would be around 40 hours. Now, they don't like it when we kind of lock it into those hours, but that's just to give you kind of an idea of what kind of time frames you're looking at. And then the residential treatment is really hard. They are out there, but it's hard to find treatment facilities like they were when I first came into the field, where a year to 18 months was pretty much the norm for long-term residential treatment. They're still around. They still exist, but they're not anywhere near as plentiful as they used to be. And then the halfway houses or three-quarter houses are kind of designed for people who need somewhere to live but are in active recovery and need a really good support system. People that don't have the kind of support system at home that might be required to assist them along the way in their recovery. So this is kind of what we use the halfway and three-quarter houses for. One of the things when we look at the basic helping skills when we're working with clients, one of the things that I've learned over the years is that it's really not helpful to blame the addict. Now, I know that sounds kind of funny, but I like to use motivational interviewing skills, and that is we're primarily just listening for change, and we'll get into that a little bit more expressly as we go along. We don't want, empathy is really about reflective listening and listening for the ambivalence. And when we do hear, when I say ambivalence, there's a certain degree of ambivalence that exists in all addicts. That is, they understand the need to change, but they also they're also stuck. And so what I want to do is listen for that readiness, listen for that change talk, listen for those statements that they make which indicate they're ready to move along that continuum. When I hear those kinds of statements, those are the statements that I'm going to spend most of my time on, trying to get them to focus on that so we can bring about that change and really spend a lot of time on that. But if I had to kind of put all of this in a nutshell, and I don't want to spend too much time on it, if I had to kind of conceptualize or synergize it all, I would just basically say listening for change and helping the person along that continuum of change. Now, I do want to say a little bit about the role with resistance. That kind of ties into not necessarily blaming them. When you look at the role with resistance in the developing the discrepancy, you're basically assessing assessing the readiness for change is what you're doing in your client without blaming. There's plenty of time to blame. I think too many counselors get into too quickly into telling the client that they're wrong or that there's something wrong. I mean, there's plenty of time to blame the client. I think initially what we need to be doing is listening for that readiness for change and helping them to move along that continuum. That tied into the motivational interviewing that we talked about. Motivational interviewing is largely listening. Like I said, listening for the change and helping the person move along that continuum. I think that most of us are familiar with DiClementi's stages of change. Pre-contemplation, of course, is that the thought patterns that a person is having prior to engaging the treatment process. And then contemplation, of course, they're actually now starting to think about that treatment process, and then preparation. They're preparing themselves. These words are pretty self-explanatory, and you can kind of go over those at your leisure. We added a little rule or change, and the reality really is that these answers can actually help you to build the answers that you get from this little ruler can actually help you to build an action plan for the person. You can build it around the kind of answers that you get from them. So it's a neat little ruler that we put in there for you to use. And you just basically take those numbers and kind of probe the meaning of those answers with the client and actually build. That's what you're basically doing, probing the meaning. What do they mean by the answers, or by the number? What does it mean to them? And then you can kind of build your plan around that. Treatment challenges or treatment interventions and challenges. Understanding a higher power, and that's not putting an idea in their heads of what a higher power is, your own version of what a higher power is, but you help them to develop their own understanding of what a higher power is for them. We do want it to be something that is not within their control. It can't be controlled by the addict. It has to be something that they cannot control, something that, what my AA friends tell me, something that is not of this world, so to speak. Most people, I mean, they choose God as their higher power, but it's not, you don't have to be a part of AA. It's, you choose something that works for you. And part of the therapeutic process is to help that person develop their own understanding of what that higher power is. Trust. Trust issues are very prevalent, or the lack of trust is very prevalent within the drug culture because of the obvious reasons. It's a culture where it's riddled with a lot of crime and a lot of things that just don't promote trust. And so these people bring that lack of trust right on into their sobriety early on. The idea or the understanding is that early on, particularly early on, sometimes long term, addicts are really going to be dealing with behaviors. The behaviors don't necessarily change when the addiction or when the addictive use stops. These people are still dealing with these behaviors that are associated with this addiction for sometimes for a long, long time, sometimes a lifetime, really. They're uncovering one issue at a time. And then your boundary issues, of course. I like to say that the clearly defined physical or emotional barriers. I mean, we want the space to be clearly defined and help the person to understand their boundaries and the boundaries of other people as well, because it's not only important that they understand theirs, but that they understand the boundaries of others. Of course, financial barriers. Addicts create a lot of problems around their substance use, generally as a result of either squandering their own money or stealing from others and thereby getting rid of any resources that they may have had. They kind of damage those opportunities with other people. 12-step programs. Generally, if I had to conceptualize it, I would say it's generally dealing with the whole person. It's about balanced living. There's a little saying that they say in the 12 steps, that live life on life's terms. God help me to accept the things I cannot change the things I can, and the wisdom to know the difference. I think that kind of conceptualizes it all as far as the AA movement is concerned. It's about living life basically on life's terms, learning to live life. I won't go into each step. I think that would be too time-consuming. But now let's talk a little bit about CBT, which is probably the most expressly used therapeutic approach in substance abuse. It's a cognitively based therapeutic, well, cognitive and behavioral, but largely cognitive. And I think it kind of got its essence from the work of Albert Ellis, rational emotive therapy. I think it's kind of an extension of that. If I had to conceptualize CBT, I would say you think before you feel. And I'll tell you a little story before I leave you here. You think before you feel. How do you know what to think what to feel if you don't think about it first? It's a little story that I was working with a client some years ago, and we kind of started talking about Walmart and parking and that kind of thing. And I said, okay, you pull into Walmart, and you and another person see a place at the same time. It's right near the door, and it's at Christmas time. You know, the wall. You know, if you don't get this part, you're going to be 100 miles away from the store. So you both see it at the same time, and you both go for it. Well, they beat you to it. What is your feeling around that? Well, my client told me at the time he's mad, he's upset, and I said, well, why? And he said, because they took my space. I said, well, was that really your space? Because, see, Walmart, they are willing to allow anybody who's willing to go into that store and spend money. That parking space belongs to anybody that is willing to go into that Walmart and spend money. So, one, he kind of puzzled, and you can see this pondering look on his face. And that's kind of what we want clients to do. We want them to stop, think, process it. We want them to spend some time in that thought process. And a lot of times they'll come away with a different feeling on it once they process it, because the spot really didn't belong to him. The spot truly belongs to Walmart, and Walmart will rent that spot out to anybody for a certain amount of time who's willing to go into that store and spend money. So the thought behind that is, it's really not your spot. Okay, you're a little upset because you didn't get the spot, but it really didn't belong to you. That person had just as much right to that spot as you did. Who knows? They may be going in that store to spend even more money than you were. So we don't know. So then the objective then is to change those negative thought patterns.
Thomas,
Yes.
we're really running over on time, and we do have questions that I want to ask of both of you that have been submitted. Could we go ahead and skip down to slide 30 and just focus a little more on the financial piece? Yeah, right there, because that's what some people are asking. Thanks, I appreciate it.
Okay, as we mentioned earlier about Claudia Black and dysfunctional family patterns, we want to get into core issues in dysfunctional families, the financial need versus the want, which is conflicted, the want congruent. And this is from the, I think I'm saying this right, this Jargon Unified Model of Treatment of Addiction. And basically what this says is, I want to spend what I want, when I want. And that's the mindset of the addict. The addict, when someone starts using, their developmental level is stuck at that time of use. So I want what I want, when I want it. I want to live without a budget. I want to be stingy and make people live miserably like I am. But what we want to do as clinicians and change the thinking, as Anthony said with CBT, we want to be wise and be responsible. We want to be free from debt. And basically, drug addicts can be very underhanded when getting their fix. They can take family valuables. So families, make sure you lock your valuables up. Maybe keep it in the bank in a safe deposit box. Does the addict have control of your credit card, checking account? Don't share your credit card and these things with the addict. Lock your purse up and these kinds of things. So that's basically what we wanted to hit on for a minute. Case management, I heard some case managers are out there. Basically, the case manager wants to link the client with appropriate resources with financial issues, voc rehab, getting them back to employment. Voc rehab are for those who have mental or substance abuse or developmental problems and can go to their local VR wherever you are in the state. So taking control of your finances. Returning to work means you need to manage money. And so addicts need to learn responsibility. And money can be a trigger because they use it to buy drugs. So instead of buying drugs, buy food, pay rent, but be careful about falling into compulsive behaviors such as gambling and spending and these kinds of things. Establish a spending plan. Maybe give somebody, a payee or somebody, control of your money, one who's not an addict. Avoid using the ATM. Maybe place your money in an account where you physically have to go through to get the money. Finding treatment, www.samhsa.gov, the Substance Abuse Mental Health Service Administration is a federal entity where you can get a wealth of information. This is some information briefly on challenges of substance abuse programs. Basically, what it boils down in outpatient, family, co-occurring disorders, and case management is who's going to pay for it. Medicaid, Medicare, do we have state funding, grants, all these kinds of things. These are a list of resources where you can go to possibly seek out answers for that. With co-occurring disorders and family therapy, you need trained staff. What model are you using? And these are some resources and state funding opportunities as well. As again, case management, who's paying for it. And that brings us to the end. There's hope. Here are a list of resources. It's by no means exhausted, but these are just some we wanted to leave you with. And I guess at this time, questions and comments.
Well, thank you so much for that wonderful presentation. I'm sorry that we ended up rushing through the end, but we do have quite a few questions. And before we get to those, I'm just going to take it back because I would like, hold on, let me get this set. Okay, I'd like everyone to know before we answer questions that next month's free webinar is on teaching children about money. That's on June 20th at 2 o'clock in the afternoon. We have a really wonderful presenter who will come at this whole topic from a very different and really helpful and hopeful approach. And I also want everyone to know that I thought it was on this slide, but these are just some of the ways that you can benefit from all of the things that we do here at the Center for Financial Social Work. But I also wanted you to know that when you leave the presentation, you will be asked to complete a survey, and your survey will help us to make sure that we provide you with the things that you want and need, and let us know how we did on this webinar. So let me share with you now some of the questions that have come in. Someone asked, has anyone experienced a client stating they are a professional gambler. I recently had a client tell me this, and it was so interesting to see the gambling addict's way of spinning his addiction as a source of income. Do either of our presenters have a comment on that? If someone
what was that question again?
Have you ever experienced a client who said he or she was a professional gambler? This person had a client who was able to spin being a professional gambler in a really interesting way.
Well, Ms. Rita, what it boils down to is what we have as clinicians is your scope of practice. Do you have training or supervision or consultation? And just as social workers, we're taught the systems theories. So basically, what are your resources? If I can't address the needs of this client, then I maybe need to go to SAMHSA or some local or statewide resource for gambling. In the state of North Carolina, we have a lot of gambling trainings and people that address gambling addiction.
Someone wanted to know, what is stonewalling?
Stonewalling?
Mm-hmm.
I think I gave an example of that. That would basically be when it's just a clinical term that Sanning and O'Neill, renowned addiction counselors, the person basically says that I don't have a problem. So that would be in the stage of change where they're in pre-contemplation. They don't even think they have a problem, don't want to even engage in the treatment process. Leave me alone, I'm not hooked, so what? What's the problem?
Thanks, Jessica. Someone said that a couple of people wrote in saying that they feel that their population over 30, and someone said over 40%, grew up in families with addiction. And someone submitted, you sometimes see when the alcoholism skips the parents and goes to the children, the question then becomes futile. More appropriate would be if there were mental health issues in the home. I think that is in regards to that question about what percentage of the population comes from homes with addiction, where they grew up in addiction.
I don't have the specific numbers on that, but whenever we do an assessment, we do include both the genetic component. We ask questions that would indicate whether this person is genetically predisposed to the disease, whether someone in the family, father, mother, grandfather, grandmother, that kind of thing, or whether it's environmental. But I don't have precise numbers as to what percentage, but I would imagine it's quite high as far as genetics are concerned. We do have a lot of, I have a lot of clients who come from families where addiction is pretty prevalent.
A couple of people asked if they could receive the slides. We don't give the slides, but the recording, we are recording the session, and you will receive an email when that recording is posted on our website. So you will be able to watch it at your convenience. There are not CEUs associated with this session. What are some of the issues that clients still face who are still doubtful about their addiction and still spend money? Anybody?
Still spend money?
What are some issues that clients still face who are still doubtful about their addiction and still spend money? William, if you could clarify that, I'm not exactly sure.
I think the issue, Ms. Rita, a lot of times what we as clinicians we need to use supervision and consultation, and there's a thing called transference, the client transferring their feelings on the counselor, and counter-transference, the counselor responding into reaction. And a lot of times we want to see the client move along in their plan of care. We want to see them move along the continuum, get them in, get them out, build, but we need to step back and meet the client like motivational interview, stages of change, how ready is this client? We will support them in their efforts and normalize their feelings.
Okay, thanks. Someone asked, any suggestions on how to connect recently released felons with supports to facilitate living in the unrestricted world after paying their debt to society?
Well, my best advice to this population is to take it slow, take one step at a time. I really cannot enforce how important that really is. You've got a 34, 35-year-old man who feels like they still have the same aspirations and hopes as a person who may have never done drugs, and they may feel like they should be the same place along that continuum. They should have a home. They should have a new car. They should have all of these things that people have who may not have ever done drugs. These people want them as well. And so what I want to do is slow these guys down and tell them, look, you have to crawl before you walk. You may have to take that job that you don't want first before you move into the job that really pays you the kind of money that you want. And it's imperative that they understand that they have to crawl before they walk. And, education along the way, and both rehabilitation is a good place to go and tap into those resources.
Someone said that your discussion appears to be making the assumption that all addicts are either in prison or not working. What statistics do you have to back up that implication?
This is not a statistical presentation. This was just to provide a brief overview. We only had an hour, and we're not making assumptions that all addicts have financial problems. These are just some of the issues. This is just a particular aspect of addiction.
I agree with you. Someone wanted to see that list again of resources. I'll tell you, if you go to our website, go to Financial Social Work, and there are numerous places you can contact us from. If you contact us, I will send you that list of resources. Okay. Well, that seems... so money is true motivator for change. Is it a fair statement to say that the addict's relationship with money is already distorted? So is money a true motivator for change when dealing with addiction? Can you name some of the best motivations for clients with addictions?
I don't know that it's necessarily already distorted. Drugs are expensive, and when you go that vein, and the more you use them, the more it costs, and the more you develop a tolerance which requires more and more and more. And then there's other behaviors that are associated with the drug use, losing money other ways, being robbed, or just squandering money. There are a lot of things that go along with that. So I don't necessarily believe that people have a bad relationship with money to begin with. That's not necessarily true, no.
Okay. Well, that seems to be our last question or comment. I'd like to thank everyone who stayed with us. I'd certainly like to thank Jessica and Thomas for all of, someone asks, what are the costs of addictions on society, and is it up to the addict to pay their treatment? I think
well, that's a broad question, but in essence, we see here that it can cause cancer, a lot of medical problems, lots of medical expenditures in our medical arena. It costs marriage, it costs families, it costs a lot of things.
Yeah, and somewhat beyond the scope of this session. There's another question from Marina. Hi, Marina. As an EAP counselor, I see managers who have enabled their employees. The employees are taking long lunches don't come to work for several days and sleep at their desks? How can we help the managers help the employee without enabling their addictive behavior?
I think we need to help that manager understand that we're not helping them. It's kind of like the family, and I'm kind of an analogies guy, so I learned that way, and I guess I assume that other people do as well. But it's kind of like a guy who's walking on a tightrope. If you take the net from under him, you know, as long as that net is there, he doesn't really have to think about his next step. He can kind of just walk, and because he knows that the net is up under him. But now if you take that net away, he has to make every step count. He really has to think about it because each step could be the last one. So if we can kind of infuse that kind of thinking into this manager, that you're really not helping this person, and you would be helping them if you hold them accountable. It doesn't necessarily mean that they have to lose their job over it, but they need to be held accountable so that they can make good decisions.
And just like the parallel process, there's the parallel process from the client-therapist relationship, the client-agency, client-employer, and we just have to mimic those parallel processes of expectation of accountability.
Thanks, Jessica. Thanks, Thomas. I thought you did a great job. Thanks, audience, for staying with us. And I hope we'll see you at future webinars. Don't forget the next one is June 20th on teaching children about money. Okay, everyone, have a more money-wise day. Bye now.
Bye, Miss Rita.
Bye-bye.
Hey, bye. Thanks, guys. You were great.
And you said we can go back on your link and pull it up as an archive?
You'll get it. Yeah, I'll send you the link as soon as it's